Great. Um, well, it's my great pleasure today to introduce the Michael S. Aldrich Commemorative Lectureship for this year. It's actually, we invited Dr. Redline towards the end of last year, but this was when we could schedule it. And so just to say a few words about the history of this lectureship, I think this is number 19. And it celebrates the career of Michael Aldrich, who founded the sleep program at the University of Michigan in 1985 with the help and support of Dr. Sid Gilman, and really developed it into a nationally and internationally recognized program before he passed away in 2000. And he was known for making seminal contributions to both the field and its development with the board, for example, the first board, and the science with contributions to sleepiness and narcolepsy in particular, and was really known as a consummate clinician, researcher, and educator. And his vision and achievement is largely the direction that we've tried to pursue in the many years since. And so we're honored to have this lecture where we invite one of the world's luminaries each year to give it. And so it's my great pleasure to introduce Dr. Susan Redline this year. I've known Dr. Redline for about 20 years because of convergent research interests. But even before that time, especially since that time, Dr. Redline has really become a luminary, international luminary, driving the field forward with the type of work that she does, which I'll explain. So Dr. Redline holds the Peter Farrell Professorship of Sleep Medicine at Harvard and is Professor of Epidemiology at the Harvard T.H. Chan School of Public Health. She directs a program in sleep and cardiovascular medicine, and also another one in sleep medicine epidemiology at Brigham and Women's Hospital. And her research includes epidemiological studies and clinical trials that focus on the sources of sleep disorders, including the genetic and early life developmental factors, but also works extensively on cardiovascular and other health outcomes of sleep disorders and what opportunities we have through them to improve health. Dr. Redline leads a transformative sleep reading center. I can't tell you how important it's been to the field in terms of multi-center trials that all send their sleep studies for high quality, rigorous scoring and analysis through NIH funding in that lab. Dr. Redline has led a large number of cardiovascular and neurocognitive outcome studies of sleep disorders, and also interestingly founded a national sleep research resource, which makes the data available from all these large trials available to all kinds of researchers around the globe for further analysis as a repository. And Dr. Redline has authored over 600 manuscripts. I think last I saw, I didn't know that H indexes went so high. Yours was like over 120, if I remember. I mean, it's truly impressive. You've served the field in many other ways, including the boards of the Sleep Research Society and the American Academy of Sleep Medicine. And we are just totally honored and pleased to have you today to deliver the 19th Commemorative Aldrich Lecture.
Wow, Ron, thank you for that very generous and kind introduction. And especially thank you for this honor of really speaking with you today. As Dr. Chervin has mentioned, I really have just treasured my relationship with Dr. Chervin, and through our work together over so many years have also appreciated what a stellar sleep center is at the University of Michigan. And I fully appreciate the opportunity to really acknowledge the founders and Dr. Aldrich's contribution through giving a lecture today. So again, thank you very much. I'm going to share my screen now. Okay. Can you see this now? Yeah, okay. So just to begin the obligatory conflicts, I do get funding from a number of sources, and mostly NIH, but I've worked as a consultant for a couple of companies as they've developed some protocols for sleep apnea treatment. So what I'm going to do today is really try to give us an appreciation of the complexity of sleep apnea. Once we thought it was a relatively simple singular disease, and I think as we learn more and are challenged with treatment challenges in our patients and understanding mechanisms and understanding the results of clinical trials, I think we understand that sleep apnea is quite a heterogeneous disease. So I'm going to talk about very briefly a little bit about the underlying physiology, a little bit about the sources of the heterogeneity in both mechanisms and presentation. I will review a few select observational studies and later some clinical trials, and talk about how we could link our growing knowledge of heterogeneity to better understand who to treat and how to treat those individuals. So as you know, very briefly, sleep apnea is a disorder, as you can see by this figure, where the upper airway intermittently collapses during the sleep and state, especially during recumbency, and that intermittent collapse will lead to turbulent airflow, or in other words, snoring. The collapse itself may lead to hypoxemia and hypercapnia and lead to sleep disruption, which often then leads to daytime sleepiness. The prevalence in the population is actually quite variable. It does relate to some extent how we define our apnea-hypopnea index, but also varies dramatically by age, by sex, by underlying obesity of the sample. Over the years, there's been a lot of wonderful physiology that really describes the complexity of the physiologic factors that result in this intermittent airway collapse. And it does seem that any given person's propensity for sleep apnea really reflects the overall sort of threshold of factors converging to narrow their airway through anatomic risk factors like increasing fat in the upper airway, soft tissue, including lymphoid tissue, and structurally smaller airways, as well as physiologic factors that really control the patency of the airways, muscles, the responses to collapsibility, as well as underlying ventilatory control. However, and a key theme of this talk is that despite all of this complexity, we tend to make the diagnosis using a very simple count of the number of apneas, hypopneas per hour. And we'll talk a little bit about how that may actually be to our disservice. And I also want to emphasize, despite the use of a simple count, the AHI, all the clinicians in the group who take care of patients with sleep apnea understand the clinical variability in how patients present. Patients may present with mostly daytime or nighttime symptoms, and the daytime symptoms can vary and include sleepiness or not, and may rather include fatigue or what commonly reported as brain fog. And nighttime symptoms may or not be prominent, but may include various sleep disturbances, as well as a more, insomnia, which we'll also talk about later. And as I noted, there are multiple risk factors, and you could see this in this diagram below. And in any given person, there may be more of a predominance of your anatomic risk factors versus potentially your physiologic or ventilatory control risk factors. And how you, and maybe why and how you present with sleep apnea may also reflect your comorbid diseases, whether you're diabetes or heart failure. And all of these factors may also influence the ultimate morbidity of sleep apnea on outcomes. And that may be influenced by what age you get sleep apnea and the duration of untreated disease. Now, here is a very simple diagram, again, emphasizing the recurrent cyclical nature of the physiologic stresses. And again, when the airway collapses, we'll basically have recurrent Muller maneuvers, which will create large negative pressure swings, which will create stress around the transmural pressure swings around the heart, as well as that hypoxia and hypocapnia. And these factors then will lead to arousal, which will cause fragmentic sleep, as well as surges in sympathetic activation. And those factors then will stimulate the brain to resume breathing, and you'll get a resaturation. And in fact, desaturation, resaturation is a common scenario, and the whole cycle will begin again. Now, many years ago, the importance of the sympathetic activation was identified by Dr. Summers, and he did a landmark study where he did microneurography in patients with sleep apnea and controls, and showed that patients with sleep apnea not only had surges of sympathetic activity during the night, but these surges persisted during the day. And this figure shows these surges in activity even during the day in the sleep apnea versus the normal participants. But another pathway is how sympathetic activation, but also hypoxemia specifically, may stimulate the activation of really some pro-inflammatory, prothrombotic, and even anti-stimuli. So here was some results from a large cohort study I was involved in called the Mr. Oz study, and we studied over 2,500 men for over 7 years. And during that period of time, these were older individuals from the community. There were over 600 deaths. And we showed even in a multivariable adjusted analyses that having more hypoxemia in particular was associated with about a 32% increased mortality. But what we also saw was that hypoxemia itself was associated with a number of inflammatory markers, for example, IL-6 and CRP. And moreover, that the number of elevated inflammatory markers also was associated with mortality. And when we did an analysis called a mediation analysis, where we attempt to quantify what might be the indirect effect of inflammation mediating the association between hypoxemia and mortality, we found that hypoxic-related inflammation explained about 42% of the excessive risk of death, again, emphasizing that pathway. And here is just a very simplified schema from a recent review article that my colleagues and I wrote in JACC just in this last year, that again emphasizes the key physiologic stresses, the intrathoracic pressure swings, the intermittent hypoxia and hypocapnia, and the sleep fragmentation, leading to that sympathetic activation, inflammation, as well as a whole host of other perturbations like endothelial dysfunction and insulin resistance, and then in turn leading to multiple cardiovascular and metabolic consequences, ranging from hypertension through heart remodeling and heart failure, diabetes, coronary artery disease, and stroke. And just briefly to note is that these factors, although we're not going to discuss this today, not only lead to cardiovascular morbidity, but if you look to the left side of this screen, there's also many non-cardiovascular consequences, sleepiness, quality of life, work performance, cognitive impairment, that are still very, very important to our patients and may even drive our patients to seek treatment. Now, let me just now I'm going to just review a little bit of some of the data that support these mechanistic pathways. And they obviously include experimental data, but as an epidemiologist, I focus on a lot of the observational and clinical trial data. And I'll begin with some observational studies that will have a link with the temporal associations of apnea and outcomes. And again, I'd like to point to some of the Mayo Clinic, really seminal work that used a very large database in Rochester, Minnesota. And here they reported that in most individuals, most who don't have sleep apnea, as you could see in the dark blue, the time of sudden death is usually between 6 a.m. and noon. In contrast, those with sleep apnea tend to die during the night, presumably when their apneas are occurring, again, suggesting a temporal association. Now, this temporality helps create that evidence-based of cause and effect. It helps us with our observational design. So similarly, there have been a couple of other approaches to look at temporality. So on the left-hand side was some work my colleagues and I did in the Sleep Heart Health study. And what we did was we took advantage of the fact that we essentially have time series data when we collect an overnight polysomnogram. And within that time series, in any given individual, we could find periods where there are these stimuli, that is apneas, and we'll call those cases. And then we have areas of without those adverse exposures, we'll call those normal breathing. And you could, within that study, you could control the state and an actual clock time and compare the likelihood of that apnea stimulating arrhythmia compared to normal breathing resulting in arrhythmia. That's called a case crossover analysis. And doing that analysis, we estimated that the odds of an arrhythmia, whether it was paroxysmal atrial fibrillation or non-sustained VTAC, was about 18-fold more likely in any given individual, so no confounding, to follow an apneic period than a period of normal breathing. And what that really meant is that a person with moderate sleep apnea has a risk of having an excessive arrhythmia about every 6 to 7 months. Now, on the right-hand side of the slide, more modern technology that allows us to monitor people with both for sleep disordered breathing and for atrial fibrillation burden over months, also makes that temporal link. And what you could see on the top is really the sleep disordered breathing activity over time that's monitored. And on the bottom, and this is by Dr. Linz and colleagues, they show the daily AF burden. And you could see there is a temporal association. There, more sleep disordered breathing results in more AF. So again, this is how we can use some observational data to actually understand a little bit about the temporal links. Now, there are also
Dr.
ways.
Redline, can I ask a quick question?
Yeah.
Sorry, I'm sorry, I didn't know if it would be in the chat. Can you go over a little bit on how in those studies hypopneas are being defined? Are these primarily with a 4% oxygen desats from the sleep part or cortical arousals? And how do you think that is influencing?
Yeah, it's a great question. In this particular study, we actually used an event based on amplitude criteria itself. We also looked at the different levels of hypoxia, and that did influence things. But I'm going to talk about AHI measurement a lot later. And maybe what we could do is loop back to that, because that's a very important question, although I frankly think the AHI is not the fundamental metric we want to focus on. So can we link back later?
Yes, thank you so much.
Okay, so now maybe to go forward, the other temporal way we look at observational data is to collect prospective data. So one of the actually largest studies, although it did not include gold standard sleep studies, we had home sleep apnea tests, was the Hispanic Community Health Study, which was a 4-city study that did sleep apnea testing on almost 14,000 or over 14,000 people, and then looked at a variety of health outcomes. And here's a fairly recent longitudinal analysis from our group that looked at the group that had that sleep apnea testing and did not have prevalent hypertension or prevalent diabetes, and looked at the likelihood of having developing new hypertension or diabetes given an AHI, and this happened to be defined with a 3% DSAT over time. And what you can see is that even after adjusting for multiple confounders, and that's the top half of this figure, both men and women, but you could see it in blue, the combined sample, were more likely that there was about a 1.6-fold risk of developing incident hypertension, even for mild sleep apnea in this very large cohort. And likewise, there was about a 1.3-fold increase incidence of diabetes. Now I'd like to just share a cross-sectional study because I know this audience is very interested in neurologic diseases and stroke. And we know that one of the most at-risk populations for stroke is African Americans, who also have a high prevalence of resistant hypertension, and poorly controlled blood pressure is clearly a risk factor. So in the Jackson Heart study, which is essentially a study of African Americans in Jackson, Mississippi area, we also did home sleep apnea testing here, also with a 3% DSAT, although we got similar findings with a 4%. And we focused on those individuals who had a diagnosis of hypertension, so 670 of those. And what you could see is, though, on the left-hand side, the prevalence of severe sleep apnea and AHI greater than 30 increased progressively as blood pressure control became worse. And on the right-hand side is the results of some simple logistic regression where we estimated that those with an AHI of greater than 30, even after adjusting for multiple other factors, including perceived stress and depression and smoking and so forth, were 8-fold more likely to have resistant hypertension than those with an AHI of less than 5, suggesting that especially in the African American population, severe sleep apnea may be a contributor to poor blood pressure control. Now let's turn to some of our harder clinical outcomes, coronary heart disease, stroke, and heart failure, as well as arrhythmias. And here's just a summary of the literature that describes the prevalence of sleep apnea using various definitions. So when you use a more lenient definition, you'll have a higher prevalence. So clearly there's co-aggregation of these particular, of sleep apnea with cardiovascular disease and cerebral vascular disease. However, there also are prospective studies that tend to look at, as I sort of alluded to a little bit before, the incidence of these diseases. But what I want to stress now is there's quite a bit of variability in the strength of the association between sleep apnea and incident disease, according to what outcome we're looking at, particularly differences between stroke and coronary artery disease. But we also see within any given outcome, many differences across males and females and by age. And these two studies, both from the Sleep Heart Health study, really, and again, they're over 10 years old, but they were a large study, really emphasize those differences in outcomes as we model sleep apnea here using different categories of AHI. So what you could see for the stroke data with increasing categories of AHI, and it turns out that we use the AHI 3P, or arousal in the stroke paper, you could see in the highest quartile of AHI, which happened to be an AHI of greater than 20, we had almost a 3-fold increased risk of stroke compared to an AHI in the lowest quartile or less than 4 to 5. So a very strong association that we saw in the first 2 quartiles, but particularly that last quartile. Now, in contrast, we see a much weaker association with coronary artery disease. And interestingly, this analysis used the AHI of 4P, and it had slightly different cutoffs here. So an AHI of greater than 30 using the 4P was associated with a 40% increased incidence of coronary artery disease. That was not significant, although, was suggestive. And this wasn't due to the differences in the AHI 3P or 4P, but I did want to sort of point out that even the same investigative group cannot agree on how to define AHI. Those data from Sleep Heart Health about 10 years ago were included in 2 meta-analyses that then looked at the association of sleep apnea and stroke on the left and coronary artery disease on the right. And what I wanted to emphasize is really they were very much driven by the largest study, which was Sleep Art Health. And again, what we see is a much stronger association for stroke than coronary artery disease. And also, and I should have emphasized, the prior slide was in males only. And we saw a very weaker association in females. And that really comes through too when we look down here at the female association, which we have an overall odds ratio in meta-analysis of 1.21 for stroke versus 2.87 in women versus 2.87 in men. And what you could see, we have almost a protective association for coronary artery disease in females, and then a suggestive but weaker association in men for coronary artery disease, clearly much weaker than stroke. More recently, in again, sort of maybe a head-to-head comparison of stroke outcomes versus coronary artery disease outcomes from a Spanish network study of looking at patients referred to sleep clinic, you get a similar story where on the left, you see that there is a more than 3-fold increased incidence of stroke in those with severe sleep apnea here, described as an AHI greater than 3 who are untreated. And that's compared to the reference group here in black. And then you see a weaker, about a 2-fold, and in this case, probably because of sample size, non-significant increased risk of coronary heart disease. So again, a very similar story. We seem to see stronger signals for stroke. Now, why may we see, stronger findings or different findings, perhaps, as we quantify our sleep apnea exposures and look at outcomes for things like stroke or coronary heart disease or MIs, arrhythmias or heart failure? And I suppose we again have to acknowledge that sleep apnea is a complex mechanistic disease. It has different etiologies that result in different physiologic stressors. And those stresses are varied. They include autonomic dysfunction. They include various types of abnormalities in blood pressure that range from acute surges in blood pressure during the night to sustained blood pressure outcomes during the day, which can cause vascular injury, cardiac remodeling, changes in the autoregulation of blood flow to the brain, differences in inflammation and prothrombotic pathways, ischemia and cellular injury, and even cardiac stretch due to those, occlusions of the airway and the Muller maneuver. And one could imagine, for example, that cardiac stretch may be most important for maybe some of the atrial arrhythmias and maybe heart failure, whereas perhaps sustained hypertension effects may be most significant for stroke, whereas inflammation may be most significant for MIs. And it just emphasizes maybe the theme of this talk, which is thinking carefully about mechanistic and the heterogeneity of this disease. But it's not only the heterogeneity of as relates to outcome, but again, recalling that each of our patients with sleep apnea has a different constellation of physiologic findings, genetics, and lifestyle exposures. And these may, thus the outcomes of sleep apnea may be modified or moderated by sex and gender, your age of onset and duration of disease untreated, your physiology. I'm going to spend a lot of time sometime talking about the different mechanisms that lead to sleep apnea. There's what we call those endotypes, and how they may relate to differences in autonomic nervous system responses or affect sleep state dynamics, as well as the fact that other sleep disorders are also common with sleep apnea, and they may modify your end organ responses. And then, of course, genetics, even your predisposition to responding to a given level of sympathetic activation or hypoxemia with differences in inflammatory responses or angiogenesis may be very relevant. And then, of course, lifestyle. And I think we haven't actually spent a lot of time thinking about how factors like smoking, diet, and physical activity may not only predispose to sleep problems, but may moderate how sleep apnea in particular may affect your cardiovascular responses. So one particular lens that I like to use when I think about heterogeneity, I think it's the simplest way to begin when we think about precision medicine, is gender. And it's an easy way to split half the population as a first cut, knowing that it's still pretty gross. And those of you who read sleep studies are very aware that just by looking at polysomnograms, women's sleep studies look different. They tend to have more hypopneas and fewer gross apneas, suggesting a less collapsible airway. Also, their apneas are shorter, and that really suggests they more easily arouse to stimuli, so they may have more fragmentation but less hypoxia. Their apneas also tend to be in REM sleep, where there is more hypotonia, and they seem to be relatively protected in non-REM sleep. They may have less positional sleep apnea. Women tend to report less sleepiness, but more fatigue, insomnia, and depression. And here is just, I work with the Society for Women's Health Research, and we actually published with patient input really a sort of a tear-out paper to empower women to ask about their sleep apnea. Now, one of the interesting things we came across as we were trying to understand some of the gender differences was that, in fact, if we didn't look at the AHI, but we looked at a different marker that we were finding was genetically determined, and that is the apnea-hypopnea duration, we found a few very interesting issues. So the apnea-hypopnea duration is in fact a marker of your respiratory arousal threshold, and it does correlate with, or it seems to be a marker of the extent to which you may have an autonomic nervous system response to any given breathing pause. We found actually it's very genetically determined of all the simple traits we looked at, especially in African Americans that had a heritability of 60%. And we found a few GWAS significant associations. And we found that it does, across several populations, the duration of events are shorter in women, and interestingly, also shorter in individuals with African ancestry. And as you could see on the left-hand side, when we actually look at short event duration as a predictor of all-cause mortality, we find that in both men and women, and this is the Sleep Out Health data, those in the shortest quintile or quartile of event duration had about a 30% increased risk of mortality, even after adjusting for AHI. And those findings were much stronger than a comparison study looking at AHI alone. So it really, again, sort of maybe emphasizes that, especially when we think about risks, different stressors, and that if women have these short events with high arousal, that maybe just the count isn't sufficient. And maybe this event duration is a marker. And our group has begun to further embellish that. I'm not going to have to, how we actually try to look at more ANS type markers in women. But I also wanted to point out the other important thing about understanding, the literature is to understand that even our longitudinal studies are quite limited. And we usually measure our men and women at only one point in time. And often it's when they're middle-aged or older, and then we follow them for a few years. But that may impair our ability to understand the effects of sleep apnea in the population, but particularly in women, because we know that sleep apnea tends to increase fairly abruptly around the time of menopause. And and if you can look and that in fact, if you only studied, like in the Sleep Heart Health study, we studied folks when they were a mean age of 62 years and then studied them to 4 to 6 years. So the duration of basically untreated sleep apnea would have been much shorter in women. You could see this red line here when we actually first studied them compared to men whose onset of disease may have been a good 10 years longer. And for outcomes like coronary artery disease, which is a chronic inflammatory condition, maybe that is one reason, or we did not see initial results in the Sleep Heart Health study. So this, we had tried to address this when in a subsample, the Sleep Heart Health study called the ERIC study, we were able to get as much as 15 years follow-up on outcomes that included heart failure and death, as well as outcomes related to left ventricular mass. And on the left-hand side, interestingly, what we found was in women, we had a stronger association with a hazard ratio of 1.26, predicting risk for heart failure and death in women. That was more significant actually in men after, years of following these women, predominantly untreated. And that was adjusting for multiple factors. And then when we looked at left ventricular mass index, during the period of follow-up, what you could see on the right-hand side is that men do have a higher LV mass index than women, but it really did vary according to severity of sleep apnea, where in women you see this marked increase, especially as you go to the severe group. And interestingly, when we did the sleep studies, when the women were a mean age of 62, we had stored blood. And we assayed that stored blood for high sensitivity troponin, which is a marker of subclinical coronary artery disease. And what we found was, again, men at any given sleep apnea category have higher troponin than women. But in women, you see this dose response association of troponin with sleep apnea severity. And when you do a mediation analysis, you do find that those troponin levels, which were present years early when we did the sleep study, really did partially mediate the risk of heart failure and mortality, suggesting that these women were at increased risk, but we needed to follow them longer. Now, not only gender, but there is also heterogeneity in the effects of age or race on our clinical outcomes. And in this slide, I'm showing cross-sectional data from the MESA study, which is a multi-ethnic study from 6 sites across the US, and a sample study when they were about 67 years of age, and they had carotid ultrasounds. And what you see in the younger group, which is here defined generously as less than age 68, we have a significant association with plaque with a basically odds ratio of 1.47, only in those who are less than age 68, and a complete null association in the individuals with more advanced age. And then on the right-hand side, when we look at carotid intimal medial thickness, is another sort of measure of carotid atherosclerosis, we actually see that a measure of hypoxemia, the percent time with a less than 90% desaturation, was associated with this finding, but again, only in younger people. And interestingly, when we explored associations across several different race ethnic groups, we only saw it in the Blacks. Now, I also mentioned that another moderating factor may be comorbid sleep disorders, which are quite common. Just briefly, we've now become aware of the very high prevalence of what's called COMISA, comorbid sleep apnea insomnia, which may affect 30 to 50% of sleep apneic patients. And various studies have showed that this disorder, even maybe more so than OSA, may increase risk of hypertension and mortality. Periodic leg movements. These leg movements also trigger arousals and surges of sympathetic activation, and they may trigger ventricular arrhythmias as well as associated with cardiovascular incidents. And then if we just look at sleep stages itself and know that there is variation, some of it's due to the sleep apnea, and some of it also may be due to many other factors that relate to an aging brain. And we look at N3 sleep, the time of sleep that should be restorative. It should be when our parasympathetic system is most activated and our blood pressure is down. However, when we have a reduction in N3 sleep, we find that even after adjusting for AHI is associated with incident hypertension, and it's also associated with prevalent coronary artery disease and atrial fibrillation. I'm just going to go. So what are a couple, and now I will also talk more about some of the other moderators of cardiovascular risk. So as I mentioned before, I think an underappreciated factor is how lifestyle may interact with sleep apnea to modify risk. And so in one analysis done by Luke Donovan, who's now at the University of Washington, he looked at sleep-out health data, and he hypothesized that because smoking can cause endothelial dysfunction, and because, and in fact, we know that actually endothelial dysfunction and sleep apnea, that association appears to be stronger in women than men for reasons that aren't fully understood. So he tested essentially a three-way interaction between gender, sleep apnea, defined as a moderate sleep apnea and AHI greater than 15, and smoking, being a current smoking. And he found that group had a 4-fold increased risk of cardiovascular incidents compared to the reference group of male non-smokers without sleep apnea. And although there's a lot of limitations to that study because that stratum were very small, I think it just makes this point that the effects of sleep apnea may vary according to other background factors, including factors that may modify endothelial dysfunction. Now, another factor other than lifestyle, what's the opposite of lifestyle we think about? It's genetics. So when we think about genetics, you know, we each have a different genetic risk for coronary artery disease or for cerebral vascular disease. So one of my postdocs did, I think, a very interesting analysis. And what he created was he used data from the UK Biobank and created a pathway specific, meaning pathways that link genes to coronary artery disease, to find out if having, you know, genes enriched for coronary artery disease may moderate or interact with the presence of sleep apnea as predicting coronary artery disease outcomes. So what he did was he created these polygenic risk scores that describe your likelihood of having different types of coronary artery disease risk, and asked, do they interact with sleep apnea presence or absence as it related to developing coronary artery disease. And what he found was that individuals who inherit a set of genes that are in the VEGF pathway, the vascular endothelial growth factor, that normally in the general population would increase coronary artery disease risk, that in the presence of sleep apnea, there was actually a reduction in coronary artery disease risk. That is, having these genes that may in fact modulate inflammation in response to hypoxia and may even promote angiogenesis may actually be protective. So there was heterogeneity in the association between your susceptibility to coronary artery disease according to the genes you inherited. In particular, he pointed to this VEGF pathway. I know that's complicated. I could ask questions later. Okay, but now let's actually, now that I've talked about all this heterogeneity, I want to go back to one of the messages and the questions. And that is, given all this heterogeneity that I spoke about, you know, why do we use the AHI? And for one thing, it doesn't really characterize patterns of breathing or dynamics. And if you look at the bottom slide, this same person may have the same AHI, but different levels of collapsibility and different durations of events, which may lead to differences in fragmentation and hypoxic burden and autonomic nervous system responses, which really, in other words, the AHI does not give us any information about the mechanisms leading to sleep apnea or the susceptibility to sleep apnea related outcomes. what can we look at other than AHI? You know, one very simple metric, given the primacy maybe of hypoxia in the pathway, is simple measures of hypoxemia. And here's just some data that this is from the Mr. Oz study, which is a 6-site study of that I quoted a little bit earlier about mortality. But in this particular analysis, we looked at, you know, almost 3,000 men followed for about 7 years. And we looked at the risk of stroke and fatal stroke, and found again, there was a very similar association, especially with fatal stroke, that we saw in sleeper health. But in this time, it was the hypoxia that predicted it and not the AHI. And similarly, the Mayo Clinic group has looked at incident AFib, which is a risk factor for stroke, and again found in their younger cohort that it wasn't AHI, but it was really a hypoxemia measure. So we could have the same AHI, but very differences in the duration and distribution of events, where they occur in REM, non-REM, the extent to which they cluster, the extent to which there is adequate recovery time between events. But they also, these differences may contribute to differences in the physiologic consequences, the sleep fragmentation, hypoxic burden, the pressure swings, the autonomic responses, which together may lead to differences in susceptibility to heart disease. And all of this, as we'll talk about too, may also be somewhat modulated by what type of sleep apnea you have. Is it due to mechanisms that lead to collapsibility, related to neuromuscular compensation, loop gain, or low arousal thresholds? So I've been really just totally privileged to be working with a team of physiologists, epidemiologists, and geneticists who work very closely together to try to really focus on this issue of heterogeneity. And what I'm going to review is a few key things from this group in terms of endotype variation, markers of cardiovascular susceptibility, and I think that's what I'll do. So just to, sort of back down, we now know that we can take our polysomnogram and using some sophisticated engineering modeling techniques that are based on chemoreflex models, we can model the collapsibility of the airway, the ability, the neuromuscular compensation, the arousal threshold, and ventilatory control. And what we know is about, although impaired anatomy is often, a constant to some extent factor we see as a risk factor for sleep apnea, basically as many as 2/3 of individuals with sleep apnea have various combinations of these other physiologic mechanistic risk factors, and we call those endotypes. And going back to my sex as a lens to understand heterogeneity, we've looked very closely at whether endotypes differ in men and women. And in this article that we published a couple of years ago, what we found was, in fact, women not only have those shorter events that I spoke about, but they indeed have a lower arousal threshold, lower loop gain, and are less collapsible. And in fact, those differences explained about 30% of all differences in non-REM and completely obliterated any REM differences. And what this may mean is that women may have less hypoxic burden, but greater arousal and autonomic nervous system findings. Maybe this is also associated with their reported insomnia and may relate to CPAP intolerance. In contrast, men have increased collapsibility, increased loop gain, delayed circulatory time, and deficits in neuromuscular compensation. In fact, we estimate that men, the impact of being a man leading to collapsibility is about equivalent to a 20-year age advance. And what it also suggests is that it's not just collapsibility, but we also have to think of ventilatory instability from the effects of both high loop gain and delayed circulatory time in men. Again, the endotypes can inform our approach to both treatment as well as to thinking about susceptibility to cardiovascular disease. Now, this work is under review now, but this is a 3-cohort analysis from the Mr. Oz and Cleveland family study, but just briefly also shows that being obese, and being older are also associated with endotypes related to increased collapsibility and loop gain. In contrast, having an Asian American background is completely associated with increased collapsibility. And interestingly, having an African American background has a favorable collapsibility and compensation profile, but higher loop gain. That was totally unexpected. And again, the reason this may be important is that there is now this notion that you may want to target these emerging therapies for sleep apnea based on your endotype. And here's a beautiful review article by Shiro Chavahari that really pointed out, for example, if you have increased loop gain, you might use oxygen, a low arousal threshold, hypnotics, poor airway tone, hypoglossal nerve stimulation, and so forth. And again, sort of the treatment implications is that perhaps the older obese and male patients may be most susceptible to some residual apnea if you only look at anatomy. And in some cases, you may have to target loop gain. In contrast, in women who have a low arousal threshold, they may be less tolerant to CPAP. They more likely be able to wake up from CPAP, and they may not actually do very well with wake-promoting drugs, but you may also have to think about targeting their arousal threshold. In contrast, you would anticipate that maybe individuals with Asian ancestry may have particular benefit from interventions that target anatomy. And these endotypes may not only be important, as I've said, to target intervention, but go back and predict what are the cardiovascular consequences of sleep apnea. So higher loop gain is associated with the shorter event duration and greater autonomic and cardiac autonomic responses, more of a cardiac stress. The more collapsible phenotype is associated with more hypoxic burden. And those with lower arousal threshold, again, are similar to the higher loop gain with shorter event duration and higher delta heart rate. So again, trying to dissect and link the endotypes to cardiovascular outcomes. Now, my other colleague, Ali Azarban, his work has been focused on extracting these newer metrics of cardiovascular risk, and he's focused on two in particular. One, in fact, is taking the sleep studies, and in fact, you could use a simple home sleep apnea test to derive both of these. And one is the sleep apnea related hypoxic burden, which adjusts for differences in baseline saturation and really assesses a kind of a cumulative exposure related to the nadir and duration of hypoxia associated with each event, and really describes that over the night. And a more recent metric that he's looked at is delta heart rate, meaning the heart rate response to any given apneic event, which can be quite variable. And he's published a number of papers over the last 2 years. And for time, I really can't review them, but I wanted to emphasize that, using our large cohorts, he's shown that sleep apnea specific hypoxic burden predicts incident heart failure, mortality, cardiovascular mortality, and hypertension. And most recently, the delta heart rate or the specific pulse rate response also predicts cardiovascular morbidity and mortality. And in most of these studies, we found similar prediction in men and women, suggesting they may be more gender neutral than the AHI. And we also have found that there can be interactions between some of these exposures. So for example, in some cases, those with both a high delta heart rate response and high hypoxic burden were at most risk. Now, there's also, I think for time, I'm going to skip this. Okay, so let me ask the question, given all this complexity, how well have we accounted for all this, for the complexity? And do our metrics of disease express this complexity? Does our clinical management do justice? And are research studies informed? Are we trying to use really a hammer when we need a much finer, instrument? And is some of these challenges one reason we have so many issues about the evidence base we use when we make treatment decisions? So now for the very final portion of the talk, I want to now talk briefly about treatment. And, unfortunately, I saved it to the last because it's a bit of a depressing story. And in fact, recently the AHRQ came out with a big, analysis about CPAP use and obstructive sleep apnea. As much as I was upset with the report, they actually made some good points, but their overall conclusion was the published evidence does not support CPAP in terms of long-term clinically important outcomes. And we could discuss in great length about how their report was limited, but they made some good points as well. And in fact, when we look at our recent studies, the largest studies that have looked at cardiovascular outcomes, including SAVE and RICATSA and ISAC, the response is shown in this cartoon. And I hope you could read it, but the individuals are looking at the results of their experiment, saying, what is the opposite of eureka? And that's how many of us have felt. And some of our explanations are that maybe our AHI, which we use as entry criteria for the study, are really limited, but also that our study designs are also problematic in terms of the samples, size, sample selection, the challenges with adherence, and even the short duration of follow-up. And, I know I'm running behind. I apologize. One of the biggest studies was SAVE, and I'll have these on my slides. But let me just sort of, really summarize these four of the biggest studies. Again, I mentioned SAVE was our biggest study that randomized almost 3,000 people internationally. And there, if we see the overall major adverse cardiovascular outcome in this column here, you see that actually the hazard ratio was in the reverse direction that we would have liked. Although when we looked at the adherent subgroup, there was a suggestion of a protective effect that wasn't significant. Although very interestingly, when you did a sub-analysis of using a propensity matching, there was in fact a significant protective effect from the CPAP versus usual care on this large study with an overall hazard ratio of 0.50. But again, what I want to point out, the reason these studies have been criticized are several. One, you could note that they were all relatively modest, and even the SAVE study is 1/10 the size of most of our cardiovascular risk studies. All the studies some of the studies used slightly different. They all were based on AHI, which themselves may be limited, or one used an ODI, and they all mostly looked at the non-sleepy cohort. They all had relatively low PAP uses. And so these are some of the issues that we've talked about. So how do we actually now think about overcoming some of the null findings? So as I said, one of the big bugaboos is poor adherence. And, even when we do sub-analyses, we looked at 4 hours as adequate sleep apnea, adequate CPAP, but we know that threshold is actually maybe too low because people don't sleep. People should be sleeping for more than 4 hours. And we especially want to make sure that that CPAP is used during vulnerable times, that is in the early morning and REM. And I've also tried to make the argument that PAP may particularly not be effective in certain subgroups, especially those with complex sleep apnea, and maybe women even with a low arousal threshold. And again, here's some meta-analysis that just focused on, again, if we can get that CPAP use so higher, there is some suggestion with a relative risk of 0.508, which is a protective effect. So adherence is important. How do we achieve adherence? There are multiple ways. In the Best Air study, which was a study that I did as a pilot study, we used a motivational enhancement intervention and showed that when we did this in a patient population with cardiovascular disease, that did improve adherence by almost 100 minutes a night. It was still not optimal, but it does suggest that behavioral interventions, even embedded in a clinical trial, can be very useful. Another way would be maybe CPAP isn't for everyone, and it may not relate to their behavior, but their physiology. So one could try to use a run-in period with maybe a mask or sham CPAP. And even in the best year study, that screened out the run-in about 1/5 of our patients. And certainly there is the need to identify new biomarkers. And then some very interesting recent work from the Ricazza study, which was a patient population with coronary artery disease. There was evidence that those patients, when given CPAP, actually develop more anxiety over time, that their focus on using CPAP was anxiety provoking. So I think we have to think about more behavioral interventions and how to utilize app-based approaches, telemedicine, maybe even behavioral economics to incorporate and better patient selection, and recognize CPAP isn't for everyone. I think we need to think about, again, using our endotypes to think about who is going to be most likely to have a positive cardiovascular response, and maybe to use hypoxic burden or delta heart rate as an entry criteria. And in some very preliminary data we looked at in best year, we found that those with the highest heart rate responses had the best or the biggest improvements in 24-hour systolic blood pressure. There's also a lot of controversy about whether we need, whether the exclusion of sleepy patients is adversely affecting, or selecting for a resilient sample. And right now there is a workshop going on discussing how do we include more diverse and representative groups. And I think the answer is severalfold. I think we need to have active patient engagement in our study design. We probably need to think about shared decision-making in new trials where patients maybe can opt in and out based on their own equipoise. I personally think sham is a terrible intervention, and we need to do away with that. And I think there's a lot of interesting opportunities to design smart or different adaptive designs where we might even serially re-randomize patients, including those who may fail CPAP, who then may get behavioral interventions or alternatives. And I think we have to recognize that our sample sizes are an issue. Even SAVE is 1/10 the size of major TIMI trials, as shown in this left study, where in fact the study of AFib was really of over 20,000 people. And how do we do that? We have to figure out how to simplify and scale our studies, making them more pragmatic, embedding them in our healthcare system, and looking at simple, hard outcomes. And I'd like to just also end very quickly, I know I'm running out of time, just to give my colleague, Dr. Chervin, a big shout out. He's right now, a co-leader of the Sleep Smart study, and they are in fact looking at this very important stroke outcome, both at 6 and 3 months. And again, I really like several of their design features, which include a run-in period and really just a best medical therapy control. So I'm looking forward to those results. So I'd like to just end by summarizing, and I tried to emphasize, maybe too much so, the multiple complex pathways that lead to cardiovascular disease, and emphasize possible differences for coronary heart disease versus stroke, and discuss the moderating factors of dose of sleep apnea, severity, duration of disease, genetics, lifestyle factors, factors even related to the heterogeneity of the disease. I try to also suggest we need better metrics of disease to identify those at risk for sleep apnea related cardiovascular outcomes. They may include endotypes, since endotypes are leading to the outcome, as well as direct physiologic markers of response. We clearly have a lot of challenges, and we need scalability, and we still have no idea how to quantify when someone first gets sleep apnea and how many years they had when it was untreated. And our clinical trials need to be larger, longer, more pragmatic, and smarter or adaptive. And I'd like to end by thanking multiple collaborators and studies, but again, a special thanks to Dr. Chervin and the Aldrich lecture for giving me this opportunity to talk to you. Thank you.
Thank you so much for that tour de force. Incredible work and an incredible perspective and summary. I'm going to tell people that don't be embarrassed, because a lot of people have a deadline and had to have to go, so that's fine. But why don't we try to keep it open for just a few more minutes for questions.
I guess, thank you so much, Dr. Redline. I really appreciate that. I just have a practical question, especially as we were talking about the lower hypoxic burden with women, and we're running more and more into the Medicare criteria. And I know that, like Dr. Ockley just did a paper showing that women are like 2 times to 6 times less likely to get treated because they're not meeting that criteria. How do we change that? How do we get Medicare to listen to the evidence?
Yeah, I wish I had a great answer for you. I really think that, I think we have to try to generate this evidence. I think one real interesting alternative is, rather than look at the change in hypoxia, we should also, I think, look at delta heart rate, because these women do have a prominent heart rate response, and that may indicate a stress, and that's very easily to be done even with home sleep apnea tests. So I think we have to promote that. I think also there's a lot of interest in really changing Medicare, criteria, and go away from the AHI completely and make this much more of a clinical diagnosis that's supported by physiologic tests and several different options. I don't know how quickly that's going to happen, but my analogy is asthma. We don't deny a patient asthma therapy if they don't have a bronchodilator response.
Yeah. I wish we could make that change. Thank you.
I think Neeraj, Dr. Kaplish was that.
Dr. Redline, thank you so much for a great talk. I appreciate it. I think you touched upon a little bit. I want to get your thoughts on the PAP therapy, because that's one of the outcomes that we measure, is the reduction in the AHI clinically and even in the research world. And I think in the older literature, it's talked about the auto CPAP being, when compared to the standard CPAP single pressure, the biomarkers are much lower in the standard single pressure, and also the blood pressure control is better. So I just was trying to see whether the field is also changing in that aspect, and wanted to gather your thoughts on it.
Yeah, so if I heard you correctly, it's the issue of CPAP versus APAP. Is that your? Yeah, I think it's a relatively understudied, area. I think there's been, there's been a little bit of work suggesting that in some cases APAP may disturb your sleep. But I think we also find that, maybe in other cases, both because of the convenience of the therapy and the ability to make changes over time, there are advantages. And my gut feeling is that we're going to find that in some cases, APAP is preferable, and other times it's not. And maybe people with low arousal thresholds, it's not as ideal as CPAP.
Thank you.
Dr. Goldstein?
I have a follow-up question to Neeraj's. Oh, and hi, Susan. How are you? That was awesome. So do you think there's a role, because whether you use CPAP or auto CPAP, we kind of put people on it and we leave them. So we follow them longitudinally, and we follow their symptoms of sleepiness, their blood pressure control, their PAP generated data, including metrics that we don't know how valuable they are yet. But what are your thoughts regarding, because it's more than just what we do in the lab. So I wonder about wearable signatures in the long run, particularly because of all the cardiac and autonomic information you can get for them, if that would tell us, some information about who's most at risk, even when they're on therapy.
Yeah, Kathy, good to see you. And you're always so forward thinking. Kathy and I worked on an AI initiative that she really spearheaded. And I think you're absolutely right. I think the idea that, we're so limited, I think there's so much potential to look at wearables as biomarkers. And I think even a very gross example that I showed was the work by Dominic Lintz, where he basically he correlated AFib burden with a wearable with a sleep apnea metric over time. And I think, that itself, I think is so informative. But I think, I think the idea that, we want to treat sleep apnea in order to modulate these complicated pathways that include the sympathetic, activation, inflammation, I think having biomarkers that inform us what direction patients are going in is going to be really useful. And I certainly hope some of our wearables and AI and other things will yield some of that.
All right. I think we should call it a day, call it a lecture anyway. Thank you so much. It's been spectacular and very much appreciated.
You're very welcome. And thank you very much. It was an honor to speak with you. And I'll talk to some of you a little bit later.